Um, Hello, Miss Mangal.
Yes, sir. Hello,
Have you
sir.
joined?
Yes, sir. I have joined, sir.
Yeah, and your slides are able. You're able to share your slides.
Yes, sir. I'll just try now once.
Yeah, you can try.
Yes, sir.
Hello, Dr. Jaisal.
Hello.
Sir, can you please enable that, sir? It's like a host and disable the participant screen sharing. This is not coming.
Yeah. One second, okay.
Yes, sir.
Okay. Are you enabled now?
Yes, sir. 1 minute.
I think you are co-host now, so you should be able to share your slides.
Sir, can you able to see my screen?
No, it's still. I'm not able to see the slides.
1 minute, sir. 1 minute. Able to see now, sir?
Yes.
Okay, sir.
Yes, we can see now.
Okay, sir.
Just check whether you are able to change the slides.
Yes, sir. 1 minute. Able to see, sir?
Yeah.
Yeah. Shall I make an unshare, sir?
Yes, or you can just keep the screen because anyways you'll be starting first.
Yes, sir.
So Dr. Jaisal, should I start?
Yeah, we wait for 1 minute and start.
Okay.
We can start.
Yeah. So on behalf of Maharashtra State NNF, I would like to welcome all the viewers to join in for this yet another session of continuing nursing education. So today we have two common nursing topics, but they are also very important topics. So one of the topics is feeding of a premature baby, and the second speaker will be talking about patient safety in NICU. So both the topics are very important. And before starting this webinar, just few ground rules, like all of you, please keep your stay on mute, and so that the speakers will not be disturbed. And if you have any questions, you can always put them in the chat box. So you can put in the Zoom Meet chat box, and we'll be very happy to answer those questions. So without further this thing, I'll hand over to Dr. Jaisal Sheikh, who would introduce our expert for today, Dr. Tushar Parekh. And so over to you, Dr. Jaisal.
Thank you so much, Dr. Tushar. Just joined in time. Welcome, Dr. Tushar. So we welcome all of you, and it is my immense pleasure to introduce Dr. Tushar Parekh. He is a DM neonatologist practicing in Pune at Claim Hospital and Motherhood Hospital. Starting this functional echocardiography, more than 40 people. I'm sure he will have a lot of inputs for both the topics we are going to actually discuss today. So welcome, Dr. Tushar, and over to you. I request you to introduce our both expert speakers.
Thank you, Dr. Jaisal. First of all, I thank Maharashtra State NNF for inviting me and for this wonderful initiative of nurses training program. I think Dr. Jaisal State has taken an important lead in this, and Dr. Ashish Dobre has been kind of coordinating all these sessions. So let me first introduce you with the today's speakers, and today we have topic on preterm feeding, and the topic will be presented by Ms. Mangal Bandwal, and she's lecturer in Department of Respiratory Therapy, and she's well known nationally. She by training, has completed her training in respiratory therapy, MSc in respiratory therapy, and also she has done fellowship in neonatology under National Neonatology Forum. She's been a gold medalist, and she's primarily trained in infant young child feeding training. She is obtained through BPNI, and that is the reason that she will be presenting us today with her expertise on preterm feeding. I welcome Dr. Mangal, and I'll talk about the second speaker later. I think you can start with the proceedings, Ms. Mangal.
Thank you, sir. Thank you for your kind introduction. So, good evening, everyone. First of all, I thank Dr. Ashish sir and the entire Maharashtra NNF chapter neonatology for giving me this opportunity. So today we will be my screen is visible, sir.
Yes, perfect.
Yes, it's visible. Yeah.
So today we are going to discuss about the preterm feeding. So today we will be discussing under these headings, that is the introduction and selection of feeding type based on the gestational age and types of assisted feedings in a preterm, interventions to achieve early feeding. So coming to the introduction, 1 minute. Yeah. So, as for the World Health Organization estimates that 1 in 10 babies are born premature. So, in that, so if the babies are born premature, so as we all know, they will be having a less feeding skills. So, they will be needing the assisted feeding. And even in this, remaining 9 babies. So, in that also the 50% babies only able to get a breastfeeding in exclusive breastfeeding in the initial 3 months. So it means, in short, I want to say 50% of babies will be requiring the assisted feeding. And also, according to many experts in the neonatal nutrition, the goal for the nutrition of the preterm infant should be achieve the optimal growth of the postnatal growth. So however, what is the, if you consider a normal growth in the womb, so same growth has to be continued even after the child's birth. So maximum brain growth occurs by first 18 months of life. So you may think feeding is it's a normal thing, so everyone does, but it is very, very crucial because the maximum brain growth occurs by 18 months of the life. So that is why the nutrition and the feeding is very important. And as we already know, brain is more vulnerable to nutritional deprivation, and if it is not provided, so that may lead to the lowered IQ and behavioral disorders in the long term. So coming to it's a quick quiz here. So if I ask you, so breast milk versus formula, which one would you select? A quick answer in the chat box, please. Anybody? Sir, any response? If I ask you, which one you are going to select? Mother's milk or a formula? I hope. Yes. I think you will definitely go ahead with the mother's milk. Yes? Yes. Slide is not changing.
Yes, they have responded with breast milk.
Yes. So the first thing is the first preferred milk is that is mother's own milk, and if it is not available, even the second substitute is a pasteurized donor milk. So definitely big no to the formula milk. So what I mean to say is breast milk is the best milk for the baby. So coming to the next, so now what we'll see based on the gestational age, we are going to see 1 minute. Yeah, based on the gestational age, we are going to see what type of feeding is suitable for the baby. So if the gestational is more than 34 weeks, so that time the sucking pattern will be improved, and sucking pattern is better, and there is a suck swallow coordination will be there. So definitely we will go for the breastfeeding. And coming to the next, if the gestational age is 32 to 34 weeks, So here the slightly mature sucking pattern will be there, and coordination between the breathing and the swallowing begins here. So it is not matured. So that is why we the preferred mode of the feeding will be, what's happening? 1 minute, sir. I'm not able to change a slide.
You can use the arrow. That will be easier to change the slide. So not the arrow from your keyboard, but the arrow from the screen.
Yes, ma'am. Yes, ma'am. I'm using. Yeah. So in the 32 to 34 weeks, so the preferred feeding will be cup feeding or a palada feeding or the spoon feeding. And coming to the next 28 to 31 weeks, sucking burst this time that develops, and there is no coordination between suck, swallow and breathing. So that is why here we go ahead with the tube feeding, that is a orogastric or a nasogastric tube feeding. And if the gestational age is less than 28 weeks, then there is no proper sucking efforts, no propulsive motility in the gut. So even if your feed will be not really tolerated well. So that is why the best option will be, you can give a IV fluids, or the total parenteral nutrition is required at this point. So I'll just now we already know ki based on the gestational age, we can decide this baby is fits in which category, either the breastfeeding or the tube feeding or the palada feeding, or we cannot feed the baby if the baby requires the parenteral nutrition. But so here there is one flow chart you can just see. So if the gestational is more than 34 weeks, then definitely we are going to initiate a breastfeeding. And as we all know, preterm means the babies who are less than 37 weeks. But after 34 weeks also we can initiate the breastfeeding. But still we have to observe further whether the position is proper and the attachment are good. And also the baby is able to suck effectively and long enough for about 10 to 15 minutes. Okay, sometimes the baby may suck for 5 minutes and may get tired. So that is why it is very important to make sure that baby is sucking effectively for the 10 to 15 minutes. If these criteria is met, yes, definitely you can go ahead with the breastfeeding. If this criteria is not met, then you have to take a support of the spoon or a palada feeding along with the breastfeeding. And if the baby's gestational age is 32 to 34 weeks, so this time we wait for the breastfeeding and we start the spoon or palada feeding, and you observe the child, whether the child is accepting well without so much of spilling or the cupping, and able to accept the adequate amount. If for all the there is a lot of noises coming, sir, madam. Yeah, thank you. So here, if these two criteria are met, then you can definitely go ahead with the spoon or palada feeding. And if it is not met, then we can go ahead, we can start a orogastric or a nasogastric tube feeding. So even some hospitals where I work, we can, along with the tube, you can give some amount of the palada feeding, then remaining when the baby is not accepting that time, you can give a NG or a OG feeding. And if the baby gestational is 29 to 31 weeks, so here we are waiting for the palada feeding. Here we are going to directly start with the OG or a NG tube feeding. And when you give this feeding, so all, you are going to observe vomiting, abdominal distension occurs, and also you are going to check a residual gastric residual volume. Okay, so so say for example you have given a 20 ml of the feed to the baby. So before the next feeding you are going to aspirate and see if it is more than 25%, yani if it is more than 5 ml, then it means the whatever the feed you are giving, that is not well tolerated by the baby. So that time what we do, we will not give the gastric feeding to the baby. Okay, if these signs are present, there's a increased GRV is there more than 25%, and child is having the vomiting and abdomen distension, that time we are going to start with the IV fluids. And coming to the next, if the gestational age is less than 28 weeks, that we call it as a extremely preterm weeks, for them, we are definitely going to start with the IV fluid, and also we consider total parenteral nutrition, that is TPN. Okay. So coming to the next, as I told, if the baby gestational is more than 34 weeks and the baby is healthy and his sucking is matured and the good suck swallow coordination is there, if all these things are okay, then we can definitely go ahead with the breastfeeding. And I believe that in your hospitals, you are following the, you are initiating a breastfeeding in the golden hour. So, and already we know that the breastfeeding is one of the most effective ways to ensure the child health and the survival. So coming to the, so as we all know, if the baby's gestation is less than 34 weeks, definitely we are not going to start the breastfeeding. Then we go for the another assisted feeding, that is Palade feeding. Okay, so this preterm infants who are not able to feed directly from the breast, they are introduced to have this palada spoon or a cup feeding. Okay, so this is the something called a palada. So you all must be aware about this. And in Indian cultures, these are like traditionally used. It has got a pointed tip, and here this is the container. Here you can hold the palada and feed. And also, I am proud to say that this is introduced by the Indians only, and it's a gift to the world. So other people are other outside the India also, they are following this. And this is something like this is a nifty cup. I can say it's a modified version of the Paladai. This is also made up of this silicone. Sometimes you must have noticed when the babies are very active, though your feeding techniques are correct, okay, you will be keeping this point in the corner of the mouth and you will be feeding, but sometimes the chances that baby may get hurt with the sharp end. So in that case, you can try with the nifty cup. It is made up of the silicone, and it has got a volume also, you understand here. It is a soft and you can sterilize it. And I personally use it both, and it works in all the babies. If the baby is very cranky, you can definitely use this. And what is the advantage of using this Palade feeding? So okay, even you can feed with the cup, even you can feed with the spoon, but why this Palade is like good compared to that is the spillage will be more. So that's the one advantage. So coming to the steps of the feeding, that is Palada feeding. So first thing, whenever you are going to do any procedure or whenever you're going to give a feed, the first thing you check the identity. So to which baby you are going to give a feed. And second thing, you check for the orders. What is the feed toleration? What is the amount prescribed to the baby? So for that, you are going to check the doctor's orders. And as per the infection control protocol, you are going to do the hand washing before any procedures. So I believe that you all know all the 7 steps of the hand washing. And next one is you hold a baby in a upright position and you keep a napkin around the neck. And also you can see this baby is sleeping. Can I give a feeding a baby in when the baby is sleeping? Definitely no. Okay, so you can make the baby wake up, you talk to a baby, okay, and whenever you touch to a baby, so he will get up and start showing some feeding cues. And next thing is, as we already discussed, so the milk what you will be giving, that will be a mother's milk. You can ask the mother to express the milk and give. Sometimes the mother will be not available immediately, so that time, so earlier expressed milk. So the milk, breast milk can be kept in the room temperature for 6 hours. And you can keep in refrigerator, you can keep it for the 24 hours. So that milk, preferably the mother's milk, is used for the feeding. And whatever the amount is expressed, so so you measure it in a sterile syringe, And once you measured amount is taken, so you slowly start feeding a baby. And see, this is how they are holding the this palade, and you will have to put this in a corner of the mouth and slowly start feeding a baby. And whenever you are feeding, so you have to notice whether is there any color change in the baby, whether the baby is coughing, do you notice any change in the vital signs, especially the desaturations or a bradycardia. So and so all these things you check. If you notice anything, definitely you stop the feeding and just check what is wrong with the baby, or whether your technique is not correct. So all those things you check. And once you are done with the feeding, so it is very important to sterilize all the articles used for the feeding. So you can use the autoclave, or if the autoclave is not there, so you can at least boil for 20 minutes whatever the equipments used for the feeding. Once that is done, you wash your hands, and don't forget to document what was the feeding amount of feeding you have given. Did you notice any any problems while giving the feed? So all those things you can notice here. Now you can record here. Coming to the here is a short video how to give a palada feeding to the baby. So please watch the video. So I hope this video cleared us, given the information, adequate information about how the palada feeding is done. So here is a one quiz. So I just want to ask you all, if somebody comes or some mother come and ask you, so whether sometimes they will have issues with giving the palada feeding and all. So you have two options in front of you. One is a palada feeding, one is a bottle feeding. Which one would you like to select? A quick answer. Please give me a quick answer. All are with me? Okay. I assume that you all will go with the palada feeding, because the bottle feeding, it has got a lot of drawbacks. And when the baby sucks on the bottle, so the mechanism is entirely different when he sucks on the breast, because any bottle fed babies will end up with the nipple confusion. Okay, so that is why, and also the bottle associated problems are there, and that is why no hospital will recommend to give a bottle feeding nowadays. So that is why the palada feeding or the cup feeding is recommended. So coming to the next, there is 1 minute. There is some internet issue. Yeah, so there are some in this happens in a normal preterm baby. So here we are going to select go with the palada feeding. So there are some special situation. Can you recognize this? So this is the cleft lip and a cleft palate. This is the cleft lip and a cleft palate, and this is the this you can see this condition is called the Pierre-Robin syndrome, and this condition definitely first you will be trying with the breastfeeding. When the breastfeeding is not working, you can consider to give a this feed with a special feeder. So this is called the Haberman's feeder. So you can consider this. So coming to the next. So that is intragastric tube feeding. So as the name says, intragastric tube feeding means you are going to insert a tube into a baby's stomach, and with that tube you are going to give a feed to the baby. So intragastric tube feeding is appropriate for an infant who is clinically stable. The child will be clinically stable, but he is not able to accept the oral feeds. So in that case, we are going to give a intragastric feed. So it can be given with the two routes, that is nasogastric and the orogastric feeding. So here nasogastric means you are going to insert a tube into the nostril, it will go to the stomach, and orogastric means you are going to put a tube in the baby's mouth. So here one thing, there are two options are available, but one thing we should understand, there are many studies are done nasogastric versus the orogastric. So what those study concludes that orogastric tube feeding is preferred over nasogastric tube feeding. Why? Because nasogastric tubes, by blocking one nostril, may cause the airway resistance, and baby may struggle to breathe. So there is also an increased incidence of desaturations and apnea. So where the oxygen level may go down, and baby also may have a cessation of the breathing. So that is why. So the preferred one is orogastric tube feeding based on the current evidences. So let us see which are the steps for the intragastric tube feed. So before, as we discussed earlier, first you have to identify and check the doctor's order. Then before starting to a feed, first you check whether the tube is in situ, whether it is in place. You can measure it, and also there are two methods. One is auscultation method, and second one is the aspiration method. So auscultation method is usually used in the to check whether the tube is in situ. So second one is remove the plunger of the syringe and connect the barrel of the syringe to the end of the tube, and pinch the tube and fill the barrel of the syringe with the required amount of the milk, and hold the tube with one hand and release the pinch and elevate the syringe barrel, and let the milk run from the syringe through a gastric tube by the gravity. You need not have to force the milk by using the plunger. So how you give the injection, similarly it should not be done here. It leads to a lot of problems. So let it flow through with the help of the gravity. So now we'll see what are the steps are continued. So control, how do we control? So suppose the feeding is going very slowly. What you are going to do? So control the flow of the milk by altering the heights of the syringe. When you lower the syringe, so that time the milk flows very slowly. When you raise it, the milk will run little fast. And this tube feeding should take 10 to 15 minutes. And whenever you are giving the tube feeding, just observe the baby throughout the feeding. And if you notice any any problem. So if the baby is having any breathing difficulty, or the change in color, or the baby looks blue and becomes fluffy, or there is a vomiting, please stop the feeding. Okay. And once you are done with the successful feeding, cap the end of the gastric tube between the feeds. And if the infant is on CPAP, so usually we close the feeding tube and keep. But if the baby is on this CPAP, that time after giving feed, so wait for the half an hour. Then afterwards you can keep it open. So what happens if you do not open? So it may lead to something condition called CPAP belly, where the abdomen will get distended and it interrupts with the CPAP. So after the feeding, avoid flushing tube with the water or saline after feed. So we should not be flushing with the water or the saline water or the saline. So here is a quick video. Please watch this about the intragastric tube feeding. Hope this video given us a overview of how the tube feeding is given. I just want to say two things. Like one thing is when the feed was given, the baby was in a flat. Maybe it was slightly extended, but I request you, like whenever you are giving the tube feeding, the baby's head should be elevated. There should be at least 30 to 35-degree elevation should be there. And second thing, ideally the syringes after measuring the feed, so please try to change. It need not have to be kept for the 8 hours. Okay, so every time the fresh syringe should be used to avoid unnecessary infections. So now So now we have, so far we have done with the tube feeding, palada feeding, and the breastfeeding. So there are some interventions. Sometimes the baby is 34 weeker. He is not taking the breastfeeding effectively. And we have a smaller babies who is not able to take the palada feeding. So for them, are there any interventions? Yes, definitely there are some interventions to achieve a feeding skills earlier, to come to the full feeds earlier. So in that, the first one is a tropic feeds or a minimal enteral nutrition, or it is also called as a gut priming. So what is the meaning of this? Here, the small amount of enteral feed is given. So usually it is 10 ml per kg, and it is given to the infant when the baby is medically stable, and you can give just 10 ml per kg per day, and gradually if the baby is tolerating, then that time you can increase the amount, so that it will help to like come to the complete oral feeding early. Okay, so and bolus feeding every 2 hourly. How do you give? You can give every 2 hourly, or you can give every 4 hourly. And it can be started if the baby is stable. So it can be started even on day 1. And what this tropic feed does, so hardly 10 ml, how it is going to help? Okay, it may not, definitely may not meet a nutrition requirement, but it is going to help to stimulate the GI tract, and it also prevents the atrophy of the mucosal atrophy, it prevents. And also there are the clinical benefits. The many studies are also done on this. So it helps to improve the milk tolerance, and there's a greater postnatal growth will be there, and there's a reduced systemic sepsis, and also ultimately it is going to reduce the hospital stay. And like this is explained in the one RCT conducted by Mike Clure et al. So this is about the tropic feeds. So next one is there is something called non-nutritive suckling. Okay, NNS, what we call. So non-nutritive, what is it? Non-nutritive suckling is a baby sucks without receiving any nutrition. So where if the baby is sucking the breastfeeding, so when the baby sucks, he will get some milk. Okay, so that will meet his nutrition requirements. That is a nutritive sucking. Here baby is sucking, but his main intention here baby will be not receiving the any nutrition. So that's why it is called the non-nutritive suckling. So here baby can like suck his own fingers, and it can be baby can be put on the mother's breast. So here, before keeping the baby for the non-nutritive sucking, the mother should empty her breast, then put a baby for the like NNS. And the third option is that is your pacifier. So whenever this pacifier is used, you should be very careful, because sometimes this pacifier will come with the honey which is completely banned, because WHO says up to 6 months we should not there should be exclusive breast milk feeding, not even a water. So that is why you just make sure it is just an empty pacifier, it is not having a honey and all. And also when this pacifier are used, the chances of the infection will be there. It should be like washed frequently before giving to a baby. So and what this NNS does, so it will help for the maturation from the infantile sucking to the adult sucking. Initially the baby sucking will be not so effective. Once the NNS is started, the sucking pattern will gradually start improving. And also this NNS supports that it helps for the development of the normal suckling, and it helps to achieve the suck swallow breathing coordination early. There is something wrong in the baby doing this NNS, but sometimes what happens when the baby is sucking on his thumb and all, so it should disappear by 3 to 4 years. Even after that, if it is not disappearing, it is something to be worried. So but you can ensure parents that it will be disappeared by 3 to 4 years. And also this NNS will help when you are doing any painful procedure to the baby to reduce the pain. Also this NNS will help. So the coming to the next, that is oromotor stimulation. So this is regarding this many in NICU. I think in a few NICU it is followed, but in many NICU it is not followed. And also regarding this, one Indian study is done that is published in the Asian Journal of Nursing Education and Research, and it is done in the Bhubaneswar. It's a recent 2021 study. So here, they explained about the oromotor stimulation is a developmental therapy which is used in the NICU. And so here,
Miss
what
Mangal?
is, yes, ma'am?
You are way beyond the time frame. The next speaker is waiting. I
Yes,
request
ma'am.
you to wind up.
Yes, ma'am. It's just 2 minutes, ma'am. Okay, so here the particular exercise is done to the baby. Even the first one will be when when you keep a baby on the KMC, so that time the OMS will occur. And other than that, you can do the this exercise. This is preferably done before 15 to 20 minutes of the feeding. And now we all know we have studied the different feeding. So how to ensure that whether whatever the feeding you are giving or the baby is growing well. So please try to monitor the growth charts. This is the intergrowth 21. It is a new growth chart. It is specifically for the preterm babies. It is a gender specific standard growth charts. So take home massage is the breast milk is the best milk for the baby, and initiate breastfeeding in the golden hour if the baby is term, and palada feeding and the intragastric feeding is given when the breastfeeding is not possible, and OMS, NNS and the minimal enteral nutrition will help to achieve the early feedings. So this is something for getting curve. So it shows that so whenever we learn, it immediately we grasp more, but by the gradually when the time lapses, we tend to forget the things. So please keep reading. So this is how I conclude my topic. So thank you so much. Thank you so much. Thank you, everyone. Please, if any question, please, we will discuss at the end of the topic.
Yeah, thank you so much, Ms. Mangal. So now I ask Dr. Tushar Parikh to introduce our next speaker, Dr. Amol Joshi, who will be talking about patient safety in NICU. Dr. Tushar, are you there? Hello. Yeah, Dr. Tushar, can you hear me? Dr. Tushar?
Hello.
Yeah, we can hear you now. Yeah, can you please introduce our next speaker, Dr. Amol Joshi?
Hello, am I audible?
Yes.
Yeah. Okay. Hello.
Yes, go ahead.
Yeah. No, first of all, I think I congratulate Ms. Mangal for a wonderful presentation, because preterm feeding itself is a big topic. And I think she's covered a very important aspects, practical aspects, and important take-home messages for everyone. And no amount of kind of praise will be enough to just for about breast milk, that we have to ensure. One important message I would like to, I think, say here is that when the mother comes to the NICU first time, and mother is kind of very scared to enter the NICU, see the baby and touch the baby. I think there is a very, very important role of the mother for the nurses, kind of to give a positive aspect and help the mother, and ensure positivity infusion in the mother, so that the mother is able to kind of express the milk and kind of give. Plus, of course, the mother will need to be trained and education about hand hygiene, about proper expression of the milk, technique of the milk expression and giving, because I think we have to work hard on the mother's own milk supply for the babies who are in the NICU. And so that one important message, I think, because there are a lot of things which we need to do on mother's own milk supply for the NICU babies, like right from early initiation, frequent expressing, nighttime expression, use of proper breast pumps, and oromotor stimulation, oromotor painting is also sometimes done. That will help for mother to help for the baby to early kind of have a feed tolerance. I think Ms. Mangal, you have covered all the important pertinent points, and I think I congratulate to you.
Thank you so much.
Now the next session will be carried by Dr. Amol Joshi, who is Associate Professor in Department of Neonatology, GMC Hospital, Aurangabad, and he is a national mentor for a lot of quality initiative projects, and he is a fellow of neonatology for MUHS. And so it's all yours, Dr. Amol Joshi. Yeah, you can carry forward, Dr. Amal.
Thank you for the introduction. Good evening, all. Today, I am going to speak about comprehensive patient safety in NICU. First of all, I would like to thank organizers and office bearers of Maharashtra State Chapter NNF for giving me this opportunity to talk on this forum of continued nursing education webinars. I declare no conflict of interest. I have taken the information from various sources. Nobody in the world can tell I have not done harm to any baby. We have to accept that first. Every person caring for a newborn is a nurse with variable levels of skills. And this is a safety continuum. It starts right from mother's womb. So safe pregnancy, safe childbirth, and so on. So we need to have obstetrician on board. If God grants me 3 wishes for improving newborn care, I would ask him to eliminate or prevent sepsis, 3 major killers of newborns. The flow of my presentation would be: what is patient safety? Why is it important to know? How is it compromised? Which are the acts of error? And how to ensure safety and psychological safety. World Health Organization has defined patient safety as a framework of organized activities to reduce the occurrence of avoidable harm. Very important. But then why is it important to know? Is because in US, deaths caused by accidents, aviation accidents account for only 329 of the annual deaths, but medical errors account for 120,000 deaths in a year. So the most vulnerable of the population is at the most dangerous situation in the world. Though we do not have the accidental deaths data with respect to medication errors, but yes, in Indian scenario, deaths due to poor quality of care are more than non-availability of care, even in newborns. So, what is quality of care? World Health Organization has defined quality of care as care which is safe, available timely, efficacious, efficient, equitable, evidence-based, and patient-centered, out of which safety is a very important feature of quality of care. So WHO has come up with Global Patient Safety Action Plan. So let us join our hands together for eliminating avoidable harm in healthcare. How is patient safety compromised? Here, let me show you a Swiss cheese model for error, a simple video which demonstrates how loopholes in the systems can align to cause error. So this is an organization where nothing is perfect. There is a loophole here. Unsafe supervision, there are also loopholes. Precondition for unsafe acts, there is also loophole, and actual unsafe acts performed. So only when all these four are in line that there is a error. So one practical example, in an organization where there is overcrowding, inadequate nurse patient and doctor patient ratio, and there is only a single wash basin at the entry, quite distant place from critical area, there is a policy of hand hygiene existing, but there is poor take up and there is no audit. People have apathy towards hand hygiene, they are overburdened, and the healthcare worker during night duty does some unsafe practices and poor hand hygiene. What is going to happen? So sepsis is bound to happen in such scenario. It is not only a single loophole or single limitation function. It is the combination of factors which leads to sepsis. So a breach in patient safety can cause so many different types of harms. To name a few, medical error is preventable with medical knowledge. Medication error is due to inappropriate medication use with or without harm. Risk is probability of danger. Near miss is the event that did not reach the patient, and never event is when the patient has suffered serious harm. So acts of error can be act of commission in which the healthcare worker is doing something which is not expected from him or her. For example, identifying wrong gender. An act of omission is something he or she is not doing when he or she is supposed to do. That is, for example, leaving a baby unmonitored. Nurses are eyes and ears of nursery. Hygiene is a very important aspect. Hand hygiene is the top priority when it comes to prevention of infection. We all know that hand wash before entry, before invasive procedure, after soiling of hands, and after handling contaminated surfaces is must. It should be done for at least 60 seconds with appropriate do's and don'ts. Alcohol based hand rub has to be used for around 30 seconds or till it dries with all 6 steps. And we all know about 5 moments of hand hygiene: before and after touching the patient or patient surroundings, before and after doing any procedure, and after leaving patient surroundings are the 5 moments. And appropriate use of gloves whenever deemed necessary, sterile and unsterile gloves. We all know that. But do we know whether we are actually following it? Let me tell you, there are many lapses, and even in best of the setups, hand hygiene compliance is less than 60%. Just to tell your experience, we had done a hand hygiene audit, and out of that, there are different approaches. One of the approach was checking out the sanitizer use. So busy NISU, every time the volume of sanitizer dispensed is 1.5 ml and recommended is 2 pumps, that is 3 ml. If one baby is fed 8 times, injectable drugs are given around 3 times, diaper is changed for approximately around 2 to 3 times or more, sampling or intravenous catheter insertion. So procedure like that is done for around 2 times. Every baby is having a monitor and a temperature probe which needs to be replaced in different locations, so around 8 times. So to calculate 3 into 25 times of the touches and before and after the touch, so into 2, so it comes to around 150 ml per baby per day. So if your NICU is 10 bedded, so approximately 1.5 liters, that is 500 liters of sanitizer bottles should be consumed let us introspect whether it is being done so or no. So hygiene also has the aspect of personal hygiene, where the local uniform regulations are applied. Indoor washable shoes, short sleeved uniform changed daily and when soiled. Hair to be kept short and kept away from the patient. Housekeeping protocols need to be followed for maintaining environmental hygiene. All healthcare workers should be trained in all protocols. The implementation should be ensured by quality assurance and quality improvement. Checklists and necessary audits to be done periodically, and this is all possible with administrative commitment only. So a baby is always bundled up in so many lines and tubes. So for this prevention of infection and patient safety, bundles approach has been introduced. Various bundles like central line associated bloodstream infections, ventilator associated pneumonia, surgical site infections, catheter associated UTIs, and NEC bundles are introduced. One of the examples is peripheral line bundles, where the line is inserted as per the checklist, hand hygiene is done, site preparation is done, aseptic non-touch technique is followed, and number of attempts is minimized. Maintenance bundle to prevent the infection transmission by doing scrub the hub. Needleless connector, if available, should be used, and monitoring of the site for local infection or oozing or inflammation, and removal as early as possible. So key site identification and protection is a very important step in aseptic non-touch technique. We should all know that these are the parts, key parts, which are likely to transmit the bacterial infection, should not be touched. Medication errors. How to prevent? This is a very good poster I saw in one of the SNCU mentoring visits, mentioning 10 rights of medication. So, right dose, right patient, right evaluation, and so on. For dose, preferably the electronic medical record system should be giving weight-wise doses. While writing and while ordering, please make sure that those milligram and micrograms are not interchanged. The format of orders 4.0 is slightly confusing, so it is better written as 4 milligrams, decimal not to be used in this case, and decimal before 4, it is better that you put 0.04 milligrams, so that the doses is correct and the communication to the administering nurse is correct. One should know compatible solutions for the drugs. Small dilutions need to be double checked, and infusion line dead space is a very important aspect. Infusion lines are having 15 to 20 ml volume, and if it is not flushed, we are likely to not give drug for around 1 to 2 hours for the patient. And look alike, sound alike medications have to be paid attention to. Nurse staffing may or may not be adequate. 1:1 ratio in intensive care, 1:2 in intermediate care, and 1:4 in special care. But one important thing to be stressed here is mother based in ICU, where we get a dedicated nurse and we can train the mother to do minimum nursing procedures, and she can be of great help for stabilizing the baby. Family centered care, if mother is not available, at least one of the family members can come and do the needful. So when it comes to safe environment, undoubtedly mother's home is the safest of all. Kangaroo mother care with skin to skin contact and developmentally supportive care is the safe environment for the baby. Machines with or without mothers is the most dangerous environment for a baby. I would like to emphasize here further on developmentally supportive care that we need to provide a healing environment to the baby with all 5 senses stimulated and protected, with proper positioning and handling, safeguarding sleep, minimizing pain, protecting skin, and optimizing nutrition along with the family support. We all know extreme low birth weight babies, 90% of them will get transfusion in their lifetime. Very low birth weight babies, 50% will be transfused. Why? Because we have to travel from zone of uncertainty to zone of certainty for few conditions in newborns. And only the blood test has to be done, or diagnostic test has to be done only if it is necessary for diagnosis, and it would change any treatment or outcome. Because we have bled the newborns very often, we need to give blood transfusions, and safe blood transfusions is necessary for newborns. And for safety, we need to take consent and document the indication of blood components, dose, volume of transfusion, do's and don'ts. For example, a baby who requires platelets, platelets need to be stored at room temperature and need to be agitated before actually administering to the baby, or it will form clumps and the platelet transfusion will be not useful if the already clumped platelets are transfused. One needs to identify and do the cross matching of donor with the recipient. Monitoring and checking for metabolic and immunologic complications is also necessary, and transfusion related adverse events like BPD, NEC need to be noted. There are various precautions for neonatal transfusion. I will not go into the details of it. In treatment, we all know for sepsis, we are using antibiotics right, left, and center. But to use the right antibiotic is necessary to protect the patient as well as the antibiotics. And the only way to do it is to prevent infection. We do not have newer antibiotics or new kid on the block promising alternative for critical care or multi-drug resistant organisms sepsis at present. Procedure safety. Simulation based training in real world scenarios is necessary. Standard safe operating protocols need to be devised. A procedure checklist has to be there with a clearly defined roles as to who will do the procedure, who will assist, and who will check the checklist. Safety and hazard reporting pathway and root cause analysis needs to be done if there is any deviation, and resource limitations need to be addressed. Rehabilitation and palliation is also must. Very rarely do we find such a baby in newborn. Usually we have to find the baby from the paraphernalia, all the machines lying around, search for the baby inside. So equipment safety is also important because there are so many equipments in the patient's microenvironment. All must know do's and don'ts of each equipment with the equipment hygiene. Regular and timely maintenance and calibration of available devices is must. Electrical load distribution is also to be calculated and uh, wisely distributed. But it is better to go towards humanization of newborn care with kangaroo mother care and, if possible, small family rooms. There are equipment specific electrical safety standards one should be aware of. National Health Resource Center, Ministry of Health, have published these on their website. So equipment must be FDA and CE approved product, and different IEC certifications need to be obtained as per the different electrical equipment. One should be aware of safe electric supply of an ICU. The supply of 220 to 240 volts with 50 hertz is acceptable range for most of the medical devices used in an ICU. Isolation transformer and uninterrupted power supply with battery is necessary. Earth leakage protection, miniature circuit breakers, residual circuit breakers, need to be installed for individual circuits, and their location for a particular area needs to be marked for operations in case of emergency. Every staff nurse or every healthcare worker on floor must be aware of these MCB and RCCB. Oxygen safety we have to consider for uninterrupted supply. Plan A, if doesn't work, then plan B, and if not, then plan C has to be ready for the institute and for department. In COVID, we have all been seeing use of oxygen, but we have forgotten that air is also necessary for life. So central compressed air supply is necessary for a NICU. We have to look at leakages at different points, and there should be different availability of different non-invasive respiratory supports for the newborn. So oxygen has to be rationally used, and to begin with, the inspired oxygen concentration should be started with 30% and then stepped up as per the need, so as to meet the saturation target of 90 to 95%, and it has to be titrated with the objective scoring of respiratory distress. Monitoring and tapering of oxygen should be done at the earliest. Fire safety with mock drill is necessary. Everybody must know RACE: rescue, alarm, contain, and extinguish. For extinguishing, pass is the mnemonic: pull, aim, squeeze, and sweep. The only caveat here is one should know the exact operating instructions of a fire extinguisher available in their own setup, and the limitations of powder based and CO2 based fire extinguisher everybody must be aware of. Just to complete the list, safe disposal of biomedical waste is also important, and as I said earlier, safety continuum. So it starts with safe pregnancy, then safe birth checklist, safe transfer of newborns. So early decision and early transport to NICU and prevention of hypothermia, and whenever required, delivery room CPAPs should also be used. Safe admission, timely admission, and golden hour emergency management to be started. That can be done with help of say curtailing the admission process by providing provisional admission documents, and gender and patient identification has to be properly paid attention to. No one reaches NICU with target to kill or harm, but things do happen. Reporting of errors, doing root cause analysis without blaming is necessary for psychological safety, and that leads to a patient safety culture, which is inculcated only with open discussion of errors and mistake transparently, and blame free reporting without fear of repercussions, and learning from clinical events why such thing could have happened, and leading by example. And obviously, with such incident reporting system and safety audits, the patient safety culture can be established. Communication is very important to detect and mitigate the risk involved in patient care. Any breach in safety has to be communicated. Identification and intervention for false as well as true alarms. Implementation of daily huddles to improve the communication amongst the healthcare workers. Structured clinical handover formats are also available, like ISBAR, care, class, etc. And vertical communication should always be there with timely feedbacks. This will definitely improve patient safety. So, take home messages are: hand hygiene, aseptic non-test technique, scrub the hub to be done, bundles approach, checklists, KMC, developmentally supportive care, family participatory care, teamwork, quality improvement, safety culture with safe process, safe structure, safe organization is must. Do not presume but anticipate. Don't neglect reported risk or near miss events. Don't neglect alarms. Don't neglect mother's complaints, and do not overdo. So less is more is the mantra for newborns. There are different ways to reach patient safety goal. I hope I have covered most of the topics and open for questions. Thank you.
Wonderful talk, Dr. Amol. I think it is excellent talk, and requirement for all the SUs as we take Hippocratic oath that first do no harm, and as a healthcare provider, I think it is our duty that we ensure that we do not cause any harm. It is always it is said that in current day and age, it is not about new trials, new innovations, new drugs, new medications that we need. What we need today is to utilize, implement proper knowledge and proper evidence which is there already available. But if we use it, implement it correctly and properly with a good patient safety, then we will be able to achieve our role. So basically at this point in time, we need to ensure patient safety and have quality improvement initiatives and projects in our NICUs so that we will be able to achieve our goal. Wonderful talk, Dr. Amol. The forum is open for question and answer if there are any questions.
So yeah, so I don't see any questions in the chat box, but if anybody wants to ask any questions, they can go ahead and ask now.
Yeah, so I think Ms. Sarika Nigde has written, may I request you for peripheral line bundles? That's also a very important topic. Do we have Dr. Amol? I think Dr. Amol, I think, has left. I think he had an
No, sir,
emergency.
I'm here.
Okay.
Let's join.
Yes, sir. Good evening, all. Thank you for the interest, Ms. Sarika.
Yeah, we can hear you, Amol, Dr. Amol. Yeah, you can go ahead. Yeah.
Yes. I must admit that this peripheral line bundle concept is I've taken from Dr. Suman Rao's presentation, and we usually implemented it only for the central lines, but it is equally important for the peripheral lines. And I'm happy to share a presentation to the organizers. If anybody is interested, the slides can be copied. I do not want it to be a copyright for me, so let it flow. The purpose of presentation is so that everybody should interested person should get it. So I'm open to that, and I'm happy to share my presentation. Thank you, sir.
Wonderful. Wonderful, Dr. Amal. I think it's a good. I think it will be a good handout for all the units who are participating, because as Ms. Mangal said, that I hear once and then the amount of knowledge we kind of get, it keeps on declining over a period of time unless we actually practice it. So it will be good for the units to follow. I think there's one more question. I can't see anything. One second. Chat box. There is a phlebitis score. Find from Google. Achha, so she's written that there is a phlebitis score. Yes. I mean, see, there are the patient safety is a vast topic, and I think what Dr. Amol has done is in a nutshell. He has tried to cover all the topics. When you are putting nasal cannulas, then there is when you're putting the CPAP interface, then there are scores for that. For thrombophlebitis, of course, there is one. And so in adult, I mean, there is a score for bed sores and things like that. So there are many aspects, but what is relevant, what is important, what is kind of fit into a kind of half an hour presentation, I think is excellently done. Yes, there is a phlebitis score. I think we can refer to that. And are there any other questions? I don't see any questions.
Yeah, right now there are no questions in the chat box again. Yeah. So I don't see any questions in the chat box. If anybody wants to ask, they can ask now.
You can unmute and simply ask the question. Ms. Mangal is there, Dr. Amol is there. We are happy to answer those questions. So I think there are no questions. So I think we can conclude this session. Thank you everyone for joining at this session, and see you again next month. I think with another informative CME.
Yes.
Thank you everyone. Thank you, Dr. Ashish. Thank you,
Yeah, thank you, Dr. Tushar, for your expert comments and pearls of wisdom. I think patient safety as well as is a very important topic. It encompasses so many different aspects, and I think it should be followed in every NICU. And I also thank Dr. Ms. Mangal for her informative session on premature infant feeding. So which is very practical aspects you have explained today, and actually shown the videos of how to do pallada feeding and nasogastric feeding or orogastric feeding. So thank you. I thank both the speakers for their excellent talks. And with this, I would like to conclude the session. And I hope to see you all next on the 22nd of July, where we'll be having a talk on retinopathy of prematurity from nursing's perspective. And there will be another talk from Nanded by Dr. Sandeep Patil. So I see you all on 22nd of July, Friday, 4 to 5 p.m.
Thank you.
Thank you so much for joining. Thank you all.
Thank you so much, sir. Thank you so much. Thank you, everyone.